Hello.
Sir, good evening, sir.
Hi, Dr. Tulsi.
Yes.
Hi, Dr. Amrita.
Yes, sir. Good evening, sir.
So, is Dr. Rishika going to join?
She said she'll join, sir. I'll just call her and remind her.
Okay.
She is about to join, sir.
Okay.
Sir, Dr. Ruchika also joined. Shall I start?
Okay, sure. Please do.
Hello, everyone. Today I'll be presenting on few interesting case dilemmas in refractive surgery. We'll have a discussion about different perspectives about decision making in such special situations. So, coming to case one, she's a 27-year-old woman who presented to our clinic seeking for laser vision correction. She had stable refraction and she didn't have any history of usage of contact lens, and she has no other complaints. And on examination, anterior segment was normal, and her past medical history was unremarkable. And retina revealed few pathology in it, like lattice degeneration, for which prophylactic laser was done around the lesions to adequately seal them. And her IOP was within normal limits. Her manifest refraction was unaided visual acuity was 160 in the right eye, with minus 19 spherical and minus 1 cylindrical. At axis 20 degrees, best corrected visual acuity was reaching till 612 partial in the right eye. And in the left eye, uncorrected was 2060 and with minus 10.75 spherical, minus 1 cylindrical at 20 degrees axis. Visual acuity was improving till 6.9. So she had very high myopia in the right eye when compared to left eye, and also significant cylinders. So her corneal topography shows that quality specification here we can see that it is okay, and a case or K readings are slightly to the steeper side in both the eyes. And Kmax value is less than 48. So that astigmatism is around 1.4 and 0.9 in the right eye and left eye respectively. And the thickness at the thinnest location is 556 in the right eye and 550 in the left eye, which is more than 500 microns. And the difference between the pachymetry effects in the thinnest location is not more than, it is less than 10 microns. And we can note here that anterior chamber depth in the right eye is 2.76 and 2.77 millimeters respectively, showing that this patient has slightly shallow AC depth. And her anterior sagittal curvature map shows asymmetric about eye astigmatism in the right eye with the roof, but inferior superior asymmetry and skewing is not present in the right eye. But there is slight skewing in the left eye, but there is no presence of inferior superior asymmetry in left eye. And pachymetry and elevation maps doesn't within normal limits. Nothing seems abnormal in both the maps. And bag display, Bellin-Ambrosio display shows that the thickness profiles, corneal thickness, spatial profile, and percentage thickness increase or within normal limits. They are falling within the normal slopes with normal average D value of 0.8 in both the eyes. And her OCT epithelial maps shows that central epithelial thickness is 42 in the right eye and 44 in the left eye. Eye trace summary with corneal topography and wavefront display shows normal angle kappa and alpha with higher order aberrations of 0.3 microns in the right eye, 0.2 microns in the left eye. And in the wavefront CT summary display of right eye shows that the internal aberrations in right and left eye both are more than the corneal aberrations. And we can see here that the dysfunctional DLI, dysfunctional lens index in the right eye is 2.08, which is very less when compared to left eye, which is moderate 4.26. So at this point, I would like to ask about like what refractive surgery do we prefer in this patient, and if so, why? So we chose to do RLE in right eye and femto LASIK with planned under correction in the left eye. So we chose to do RLE because firstly because of the high refractive error in the right eye, that is around minus 19 in the right eye, and when compared to left eye it is very high. And corneal based refractive surgery in going for corneal based refractive surgery in the right eye would leave very less residual stromal bed thickness, which is a risk factor for future ectasia. So we have ruled out doing a corneal based refractive surgery in the right eye for this patient. And also due to shallow AC depth of 2.7, we ruled out the second option of going for phakic IOL. And also due to the presence of poor DLI and best corrected visual acuity not being very good in the right eye, which is around 612 partial, we chose to do RLE in these patients. And in the other eye, we had better DLI and best corrected visual acuity was 6.9 in the left eye. So chances of having better visual acuity after surface procedure in the left eye is better than the right eye. And we did femto LASIK with under correction the left eye to give her advantage of monovision too.
What's the age of this patient, Dr.
Sir, she's 27 years old.
Monovision will not have much role here. However, what was the acceptance in the left eye? Can we just go back to that slide?
Acceptance is minus 19 with minus 1 in the right eye.
The left eye. Yeah.
The left eye is minus 10.
Minus
10.75
with minus 1, improving to 6.9. So this is the eye where we thought that we might undercorrect. Although, I don't know whether we should have undercorrected because, the patient's dominant eye is the left eye. So ideally, I should have been, kind of hoping to correct it to the full correction and, somehow manage to get a full correction. So how much is can we go back to that slide which shows the PTI?
Okay.
For the left eye? Okay, here. So frankly, no, go back to that slide, please. The one which is showing the PTI calculation.
Calculation.
PTA, yeah.
Percentage, okay, PTA. Okay. Sir,
PTA,
in the left eye, actually, the residual stromal bed reached to 320, as we can see in this slide. After we did under correction, residual stroma is 329.
Okay, so let me tell you here that this is not a planned under correction. This is just the nomogram being applied. Okay. For example, on the examer, on the EX500. Dr. Amrita, can you tell me about this if you are understanding what I'm saying?
Yes, sir. So, sir, this is the nomogram that we put through the EX500 when they actually look into what correction are we aiming for. So, this particular slide does not show that it is being undercorrected for the same. It shows that the nomogram is applied for. There's this chart that exists in which we see what the spherical and the cylindrical correction is. So according to that, this has been put up. But again, I also have a doubt that why did we not plan on doing a ICL in this particular eye as well, sir?
You're absolutely right. In fact, this correction is quite high, and ICL would have been another option in this patient. However,
No,
you're right
AC
that
depth
the
was
nomogram.
2.7 in both eyes, AC depth.
Right. That's what I remember. So the AC depth was small, and that's why, in fact, even in the other eye, we didn't decide to go with the ICL, and that was also beyond the range of the star ICL. That would have been still possible with a care group ICL with the IPCL. So here, Dr. Amrita, do you know the name of this nomogram, like what we use for the EX500?
So no, sir. I think I'm just skipping it.
That's okay. It's a Wellington
It
nomogram.
starts
Okay,
with
and Wellington nomogram, and this has been around since the time that the EX500 came about, almost 20 years back. And also, it was designed by Dr. Arthur Cummings in his clinic at the Wellington Eye Clinic in Dublin. So this is the one which is used internationally, and it's also the one which is given provided by Alcon with all its machines. Now, can you tell me that why do we need a nomogram? In this case, I mean, in this examiner thing, why do we really have a nomogram? Why can't in 20 years, why couldn't they kind of tweak the power calculations to not need a nomogram? Why can't it be incorporated? Anybody? Dr. Tulsi, Dr. Amrita?
Yes, we lost your voice
so the voice is cracking.
My voice is cracking?
now we can hear you, sir.
Okay, great. So I was wondering, could you make out my question? Like I was figuring out that why do we still need a nomogram 20 years after they started making this examiner, in fact, more than 22 years? Why haven't they been able to put this nomogram into the machine itself?
Because like in higher refractive errors, like it takes a bit of more time while correcting with the excimer laser, and during that time, chances of bed drying up and chances of having overcorrection is higher in high refractive errors, and so that might be the reason why the nomogram is applied.
You're right there. And however, for small corrections, we end up adding a little bit, like for a minus 0.5 or 1, we'll add a 0.25, right? Why do we have to do
Yes,
that?
not sure, sir, about low refractive errors.
Okay, so I think we are having a storm, big storm here right now. Just hold on for a moment. Let me just change my place. Is your power back, Dr. Tulsi?
Sir, it is that.
So
Luckily, just before night.
okay, so essentially what happens is that initially when you are doing a small correction like a 0.5 or a 0.75, your corneal hydration is quite high, and in fact you may have a small residual kind of a fluid thing on the bed of the cornea, which means that when you start ablating, first you will first have to ablate like a micro layer of fluid, and then you actually start ablating the stroma. So some energy is always lost, like about the initial 0.1 or 0.2 is lost in trying to ablate. So for that reason, initially when you start doing the first like small corrections, you will need to first rectify for that, and that is why the hydration is more, and that's why the ablation will be less. So you add a positive normal, I mean you add to the correction. Now, as you from say about -2 till -5 or 6, no corrections are required, because during that time no adjustments are required. And as you go beyond 6 and the higher you go, the more chances that the cornea will be dehydrated and will get ablated faster. And so you will end up getting an overcorrection if you kind of use the same nomogram which was required up till -6. So then later on, the longer, the higher the correction, the lesser, the more the nomogram application. So here, Dr. Tulsi, the 9.5 is actually because of the nomogram where we are aiming for a -1 correction. So essentially this correction will lead to a correction of -10.5 with 1.25. So we did not do a planned under correction. We actually corrected completely. You got it?
Yes, sir. Got it.
Perfect. So I think here, so don't, I mean, in case we present this again, you can change your slide to so say that in the left eye, we planned for a full correction because we had adequate corneal thickness to correct the same. And that was not possible to put an ICL because of the shallow AC depth. And this was the dominant eye, and we wanted to do a full correction. And even though the DLI was about 2 or 2.5, but patient was improving to 6.9 and was satisfied with the 6.9 vision with the glasses. So we were thinking of reproducing that vision with the left eye. But in the right eye, the vision was not satisfactory. Patient was not happy. Getting a crisp 6/12 parts also was not a good vision. So that is why we decided to go for a refractive lens exchange, because nothing would have, ICL was not possible. And even with the best correction, there was no chance of kind of achieving this kind of a vision. So that is why the DLI also was much poorer, like 1. So can we see what happened eventually? Any inputs, Dr. Ruchika? Would you like to add anything here?
So I actually just have a question. Um, like here the AC depth is just about borderline. I think it's 2.77.
Yes.
So, sir, in all these years, have you ever made an exception, like, depending on whatever the sulcus to lens rise that you're expecting, have you ever compromised, like, say, if it's just a difference of, say, 0.2 or 0.3 from the cutoff, have you ever gone below
Okay,
2.0?
so the thing is that, okay, if you look up the international FDA things or the guidelines from STAR, they actually don't want you to go below 3. Okay. And then they have a thing that, okay, you can actually stretch it to 2.9. Now, even the 2.8 is actually stretched by us. It is not recommended. Okay.
Okay.
So frankly, even the 2.8, when we use that as a option to correct it, I mean, we are actually going beyond the limits of what is recommended. All right. So frankly, there has to be somewhere, it's like the pachymetry for doing LASIK. So
Right.
Government of India guidelines were 500 and then, 490, and sometimes we come down to 480, but then beyond 480, we don't really want to go and make a flap, right?
Right.
So similarly here, I think, 2.8 is also borderline, and anything below 2.8 is frankly a no-no. And especially when you are going to have a very high-powered ICL or a hyperopic ICL. So if you have a small power like a 3, 4, 5 diopters, you might still decide because then the vault will not be so bad. But the higher you go, the more the chances that because the lens will be thicker in the periphery and thinner in the center, the chances, the anatomy, the structure of the lens will be such that you will end up having a very high vault if you're correcting like a -20 or something, right?
Right.
So in that sense, I haven't gone below 2.75. That's the lowest I have gone, because I don't want to kind of end up burning my fingers with that. And also here we should look at the AC depth profile of the AC depth, not just the central AC depth.
Right. Right.
We should also look at the profile and also the gonioscopy. And frankly, we should check AC depth on 2-3 different devices, because the AC depth may kind of vary on the optical biometer and the pentacam. It's always good to look at 2-3 devices and frankly use the one which is showing the lowest, not the highest.
Right. Right.
Are on the side of like extra caution basically. So all the same, you're right that there are people who are doing IPCLs also at shallower AC depths like 2.7 and all. And I don't know whether we should
But
really, I mean,
in
move in
this
that
case,
territory.
obviously, with a poor DLI, we were justified in just straight away going for a RLE. But
Right.
on other occasions where DLI is good, I'm just like I wanted to know if
Right.
you.
And in fact, you're right, because suppose the worst case scenario will be if the ICL is not tolerated well, you can still go in for a clear lens extraction anyway.
Right,
Right.
right.
I mean, if you've decided to do that as the last resort, and you can talk to the patient and say, okay, we are going to do this as a possible thing. There's a small chance that the ICL will not take up. And if it does not, then we'll anyways have to go for a refractive. Only thing is, patient should be willing to spend all that money.
Right, right,
Right.
right.
But you're right. I mean, that's one option. And so let's see how it came out, Dr. Tulsi.
So in the right eye, visual outcome was very good. She reached till 6.6 best uncorrected visual acuity, and
This
in the
was the
left,
clear lens exchange. Right?
yes, sir. And in the left eye also, she did well with 6 by 7.5. Was
So in the
very
right eye,
satisfying.
did we? I mean, 6.6 is best corrected, or is it like
No, sir, it was
unaided?
unaided visual acuity was
Wow.
6.6.
So how did we do the LRI also in this eye?
Um, yes, sir, right. No, sir, I didn't see any LRI marks when in post-op when I saw the
Okay.
patient.
Anyway, so that's an excellent outcome. See, this is one of those amazing cases where a 6.6 outcome on a patient who was likely to be, kind of left with, dismissed as amblyopia and high myopia and poor retina and everything. So this is an amazing case to kind of present somewhere. In fact, even maybe publish it somewhere, that, eyes which are dismissed as not being able to correct, and, how the DLI can be really useful tool to help these patients get quality vision. And fellow IC has actually improved only to 6 upon 7.5, right?
Yes, sir. But she had 6.9 vision and 6.12.
Right, right. So 6.9 is what, we have improved a little bit, right? And so did you manage to get a DLI on the left eye post-op?
No, sir, we didn't.
It'll be
So
great to see this patient with DLI post-op for both eyes. Right eye would probably show up as 10, and the left eye might show up as slightly better than the 2 that you got. Maybe I'm just thinking. It'll be really interesting to see what happens to the DLI just by doing a refractive surgery, because then we can kind of prove that its DLI is not so reliable a tool, because if DLI changes following just a LASIK procedure, then it's not really kind of giving the true picture of the lens only, right?
yeah.
So if possible, you should call this patient and
Next
do a
follow-up,
repeated
like
DLI.
I'll order
Huh?
for you. Sure, sir. So moving on to case 2, she's a 24-year-old woman who also came for laser vision correction, and she didn't have any history of contact lens use, and she had stable refraction, and she has been using previous glasses since past 10 years. Her anterior segment was normal, and other medical history was unremarkable, and she had operculated a retinal hole in the left eye, for which again laser was done and sealed. So her previous glass power was minus 5.5 spherical and 0.75 cylindrical at 111 axis, improving to 6.9. And in the left eye, minus 12 spherical, minus 1 cylindrical at 42 degrees, improving till 6.80. She's wearing these glasses since 8 years, sorry. So her manifest refraction was actually she was using a bit lower refractive power, powers in the left eye. Her manifest refraction was minus 6.75 with minus 0.50 cylindrical at 120 degrees axis, which was improving to 6.6 in the right eye, and minus 13 spherical, minus 1.5 cylindrical at 40 degrees, improving till 6.9.
Can you just show us the previous slide to see how much? Okay, so 5.5 and minus 12, and now it's 13 and.
Yes, sir, 13 and 1 point. Hello.
Please go ahead.
Yes, sir. And her corneal topography shows doesn't show any signs of keratoconus, and she had asymmetric bow tie astigmatism at oblique axis, and her pachymetry apex and thinness location difference doesn't go beyond 10 microns, and she didn't have any red flag signs and anterior posterior floats and corneal thickness maps. And in Bellin-Ambrosio display, her CTSP and PTI were within normal limits, falling within the slopes in both the eyes. And her OCT epithelial maps shows that 48 central epithelial thickness in the right eye and 52 epithelial thickness in the left eye, central epithelial thickness. And eye trace in both the eyes shows that higher order aberrations of 0.2 microns in the right eye and 0.6 microns in the left eye. And her angle kappa and alpha were within normal limits. And also this patient had internal aberrations which are more than corneal aberrations, and which were more in the left eye when compared to right eye, and her DLI was better in the right eye when compared to left eye, which was 5.07 in the right eye and 1.99 in the left eye. So this patient, we went ahead to do SMILE in the right eye and Contura femtoLASIK with planned undercorrection in the left eye. So we
used to do.
So in the right eye, actually, because she had again she had in the corneal topography, as seen here, she had AC depth of 2.5 and 2.6, which is shallow in both the eyes. So we didn't go for phakic IOLs.
Right. So this is 2 point. Can we stay at the pentacam slide for a moment?
Yes. 2 point.
Previous one, yeah. So AC depth is 2.55. Wow. So 2.6. So no chance of doing that. And did we consider refractive lens exchange?
Actually, in the right eye, DLI was moderate, so around 5. So we chose to do SMILE in the right eye. Because in the right eye we had moderate myopia. It is not very high, but in the left eye we had -13. In the right eye we had 6.75 with around 0.5 cylinders, and in the left eye we had -13. So in the right eye we went for SMILE.
So in view of the DLI, which was not good in the left eye, why didn't we go for a refractive lens exchange?
So actually, we actually thought that she was improving to 6.9 with correction, not, and also that she was being used to having anisometropia, and she was accustomed to using undercorrection in the left eye with her previous glasses. So we thought we'll give her the same effect after the refractive surgery with slight undercorrection, similar to her previous glass power. And so we planned for an undercorrection in the left eye instead of choosing refractive lens exchange and compromising her accommodation.
Right. And also, did we do a Contura femtoLASIK or
Yes,
a
sir.
femtoLASIK?
Contura femtoLASIK in the left eye.
Are you sure? Because when we are doing an undercorrection, we will most likely not want to do the additional ablation which comes with Contura, because the Contura will end up showing. So this one, see, it's a wavefront optimized, I think, in the left eye.
Yes, actually, this picture I acquired it today.
Okay. So the thing is that when you're already kind of trying to undercorrect, then you will very unlikely that you will end up doing Contura, because Contura adds a little bit to the ablation, right? So it's counterintuitive, because you're trying to do an undercorrection because you don't have enough stroma, and then if you try to add Contura to it, you'll end up ablating more. So you would rather treat the refractive error first and then correct the aberrations, rather than leave behind some refractive error and still try to correct the aberration. I mean, that's what I normally would do. So frankly, I kind of think that this eye we would have done optimized, or even an FCAT. FCAT tends to sometimes save a little bit of tissue over wavefront optimized. That's one thing which I remember, right? So
And the target refraction which is displayed here is after application of normogram, like as you
yes,
said
yes,
before. Okay.
absolutely. So see, if you notice that target refraction is kept as minus 1.75, that's after application of the nomogram. So the actual ablation depth will not be 127. It will be much more. So there you have to be very careful that your residual bed, for example, here it's showing 309 as the residual bed, but it's unlikely that this will be 309. What you have to do is in the target refraction, you have to put 0 and then see how much of that residual bed is left. So if you see that there is less than 0.001, then you can say that the target refraction is less than 0.001.
So you're not audible.
I think because of this whole thunderstorm thing, everyone's having.
Sir's mic is actually unmuted, but we can't hear him.
No, that's what I think. It's the poor, because my side also, that's why I couldn't join on time,
Uh-huh.
because when I entered home, everything was blown here and there.
Yeah, my power is again lost here, ma'am.
Here also power is going on and off every 5 minutes.
Sir is going to rejoin, I guess.
Logged out only, na? I think he'll.
Even Amrita's voice is cracking.
So till then, I think, can you guys hear me?
Yes, ma'am.
Yeah, so like I think we had, Tutsi, I had told you also that suppose we are planning some, plan of action based on the DLI alone. If we are seeing a very low DLI, I think it's always better to repeat it once.
Yeah, okay.
For that matter, if you're noting abrasions and your plan of action or your refractive decision is going to be based on that, it's always better to just repeat it once and confirm whether, especially with, once in the dilated pupil and once without dilatation, just to see where the abrasions are rising from and if, in fact, the DLI is actually low.
I'm
Hmm.
sorry, I was lost. There was a power cut and suddenly I lost connection. So, what did we? I think we were discussing about that. That it is best to first put target refraction as 0 and see what will be our actual ablation depth, and then kind of apply the nomogram so that you don't go wrong, right?
Okay.
So, what else did we discuss while I was away?
Ma'am was suggesting
No,
us
sir,
to.
I was just saying that many times with the DLI and abrasions, sometimes if we just repeat the eye trace under more optimized conditions, we find that all those abrasions disappear, the DLI gets better.
Absolutely, absolutely.
So many times when our plan of action or decision is when we are banking on the DLI, it's always better to just repeat it once more and make sure that whatever we are seeing is in fact true.
Absolutely, especially when it is low. It makes sense to
Yes,
put
sir.
lubricant, maybe,
Exactly.
and with
Exactly.
different pupil sizes also. You can actually take it with a like a regular size pupil, then a little bit of a mid dilated pupil, and then also with a dilated pupil. Sometimes the DLI will change completely.
Right, sir.
Perfect. I think that's a very sensible thought that, make sure that DLI is reproducible over 2, 3 occasions or maybe on different days. and then only use it as a benchmark. I mean, to take a decision which is so critical for the patient, right?
Especially
Great.
when we are
So at this
deciding
patient,
between an ICL and a lens exchange.
absolutely, clear lens exchange. Absolutely. In fact, so in this patient, what we did probably, according to Dr. Tulsi, can you go on, Dr. Tulsi, on this? Yeah.
The right eye we did smile, sir. Left eye we did wavefront optimize with pan under correction.
Sure.
And we got a very good visual outcome in both eyes. In
Okay.
right eye we had 6.6, and in the left eye with planned under correction we got 6.9 vision.
Patient was happy?
Our patient was happy, sir.
Perfect. So maybe again in this patient, if this patient happens to come back, we should repeat the DLI and try to see like what changes. I mean, it'll be really nice to see that where DLI was compromised and we still decided to go with a laser vision correction. What happens to the DLI? And if we should notice that the DLI tends to improve in a few of these cases, we should definitely document it and try to even publish it if possible.
Yeah. Okay.
So we could, publish on the benefits of the DLI for refractive surgery and also the shortcomings or the limitations of the DLI as well.
Okay.
So let's go on.
So this is a third patient who was a 25-year female, had stable refraction, and on examination, anterior posterior segment was normal and no remarkable medical history. And manifest refraction was -6 spherical in the right eye with -2.75 cylindrical at 20 degrees axis with BCVA of 6.6, and in the left eye 3.25 and -2 spherical and -2 cylindrical with 170 degrees axis and reaching till 6.6 corrected visual acuity. And corneal topography shows symmetric bow tie astigmatism and a case or slightly to the steeper side. And patient did not have any signs of keratoconus, and she had borderline pachy's in both eyes. And her AC depths were, his AC depth was normal 3.7 and 3.76 in right and left eye respectively. And she didn't have any signs of keratoconus or elevated points in anterior and posterior fluid. And her bad map shows a normal CTSP and PTI falling within the slopes in right eye and left eye. And she had higher order aberration of 0.1, which is insignificant, and left eye she had significant higher order aberration of 0.4, both internal and corneal. And OCT shows central epithelial hyperplasia of 62 in both eyes. We did smile in both the eyes, and so this was the Visumax planning of the right eye with a cap thickness of 100 and lenticule minimum thickness of 10 and maximum of 119, and a residual stomal bed after correction was 271 in the right eye, and in
why
the
did
left
why did we leave a -0.25 cylinder? Like, did we undercorrect the cylinder purposely?
No, sir, no.
But then
We got.
See, if you look at the bottom of this screen, you will see that on the left, remaining refraction says -0.25 at 20.
Yeah.
So we are already, ideally for this, we should have been overcorrecting, because we typically use a nomogram of 10% overcorrection for the cylinders if possible, and 5% for the spheres when doing high corrections in SMILE. So here we haven't used any nomogram for the sphere. And are we short of tissue? I mean, I'm wondering that maybe because we are short of the residual bed, maybe it's like going too thin. That's why we've done this. How much is the residual bed? So it is 271. So we are basically running short of tissue, and I don't like to go below 271 in any case. 270. So probably that's why we've kind of left behind this 0.25 and hoping to just undercorrect it a little bit and gain, some kind of better residual bed. And let's go to the other eye now, the second eye. See, here we have a residual stromal bed of 300. So here we are actually applied the nomogram. We are aiming for a plus 0.25 cylinder and only correcting the sphere completely. -3, you don't really need a nomogram because you'll end up adding like 0.15 only to the sphere. So we've not added a nomogram, but in the cylinder, we've added a 0.10% nomogram, see. and still we have a good residual stromal thickness. Perfect. So right eye, we are undercorrecting the cylinder by 0.25, and maybe we'll be left behind with actually say about a 0.5 to 0.75 cylinder undercorrection. In the left eye, we are doing a full correction. So let's see what happens.
Yeah. So on post-op day 1, clinically, it was right eye was, both eyes were doing well, but in the AR we had residual error of minus 2.25 cylinder in right eye. And when we ordered for eye trace, there was higher order aberration of 0.5 in right eye and 0.3 in the left eye, and astigmatism was corneal astigmatism was 2.94 at 101 degrees axis in the right eye, and 0.8 diopters at 57 degrees axis in the left eye. And profile in the eye trace shows that the lenticule, it appears as if the lenticule is superiorly decentered. And this is the corneal topography profile of right eye and left eye after SMILE.
So can you explain what may have happened?
So there is a lot of, I mean, comparatively, there was more superior flattening in the right eye, which led to inferior steepening. When compared to left eye, right eye had that profile both showing up in eye trace and also in topography.
Can we go back and see how much was the eye trace refraction in both the right and the left eye preoperatively?
In the right eye, it was -6 with -3 at 7 degrees. In the left eye, 4.37 at and 1.6 cylinders at 1.
So basically, that means in the right eye, although we were using 2.75 as our acceptance, but the eye trace was showing a refraction of approximately 3 diopters of cylinder. In the left, it was showing almost the same as what was our manifest. In fact, our manifest was, I think, 1.75, and eye trace is showing about 1.62. So see, if you notice on the right side, tracy refraction also tends to give you the tracy refraction at 2 mm, 3 mm, 5 mm. This is a very useful thing, because here you can kind of see whether, how the pupil dilates, how will the, cylinder change. And, we're using the mesopic pupil size, you can actually use the correct cylinder. So this slide is very, very useful, the Chang analysis. When you are doing the final refraction of a patient, this is a slide one should see and try to see that whether the cylinder is changing. For example, if you look at the bottom, you'll see that with a 5.6 millimeter pupil, the cylinder is actually 2.24. And with a small pupil, it obviously becomes a little less. It's just about 1.13. So this has to be kept in mind. I'm just trying to figure out why in the right eye. Can we go to the right eye?
Manifest refraction was 6 and sphericals 2.275 cylinder in the right eye,
Right.
20, and in the left eye 3.252.
So this is the refraction. Now, can we see in the lower part of this slide what is the astigmatism on the surface of the cornea? So that's about 2.92. Perfect. Now let's go to the slide, which again the eye trace post-op. Can we see that for the right eye? Okay. So here now on the surface, it looks like this is also pre-op. No.
It's post-op, sir.
So isn't it amazing that if you look at the lower slide, the astigmatism, the lower part of the slide on the cornea, the corneal astigmatism is still showing up as 2.94, so at 101. And can you look back and see what was the axis pre-op?
Almost same.
Almost see, it's almost exactly the same, 2.9 at 104, and post-op is 2.9
at 101.
That means it didn't do anything to the astigmatism, right?
Yeah.
It's
Yes,
quite
sir.
remarkable. So that means we ended up. Now, this is something which definitely needs to be considered and understood what is going on. Why did this happen? Also, if you remember, this patient had epithelium which was peculiar. There was epithelial hyperplasia for some reason in the central area. Did we do the post-op epithelium maps?
Yes, we did. So this was on day 1 post-op, and after that, we followed up the patient for 3 more months, and we didn't find any change in her values, AR values. So we went ahead and did a surface retreatment in the enhancement in the right eye.
Right. And how did this go? Could we find any post-op visits of the patient and see how the patient did?
Yes, sir. So these were pre-enhancement epithelial maps, and this is how after enhancement in the right eye they look like. And we followed up till day 20. So patient had 612 in the right eye, and she had AR values of plus 0.75 at 16 degrees in the right eye.
So the left eye is also showing some significant error, and the axis seems to have changed a little bit, but the right eye seems to have improved quite a bit. But I think, in fact, for the right eye, the axis is flipped. Is it?
Yes, sir. It was at 90. It came to around 100. It came to 16. And still the epithelium is stabilizing, sir, as we can see here in the right
How
eye.
many days post-op is this map? 20 days?
Yes, sir.
3 weeks, yeah.
Have we seen this patient again, Dr. Ruchika? I mean,
So this was the last visit. I think we called so this was the last visit. I think 3 weeks post-op is when we saw her last.
was the patient satisfied at this point?
I mean, she seems to be
Better than before.
she is not a very fussy patient, though she did say that quality of vision still remains poor at this point. She wasn't complaining really, but she said that I still see like quality of the vision is not good. And she was reading 612 only in that eye.
So it'll be interesting to see how she does eventually when she comes next time. And I think now for me, the funniest thing is that in spite of doing SMILE and with you correcting 2.5 cylinder, we got an outcome where the cylinder had not changed even the slightest. How
Right.
do we explain that? I don't know.
I also have a question that in this particular, and we were doing the first time when we did the procedure, the residual thickness was actually coming to quite a borderline. And then despite of that, we've planned an enhancement in this patient. So does that not make any difference to the quality of vision that we are already doing a second procedure in it?
Not really. If you're getting a good acceptance, you can actually reproduce with the examiner most often. Only thing is, if we had not been able to, like, suppose it was showing all this error and the with acceptance it was not improving, like patient was not coming up to like 6.9 or 6.6, then obviously something else is wrong, that maybe you have created some aberrations on the cornea which are not treatable with refractive correction. But if you are able to correct it with glasses, then you can usually correct it with the laser as well.
Okay, sir. And so one more thing, that like in this patient, we actually saw that the epithelial maps were a little on the higher side. So when in such a patient, if in case we had planned for a phakic lens, like ICL or something, so does that also play any role in that, the epithelial maps that we are saying, which are a little deranged, like it's a little hyperplasia. So does that also make any difference in the quality of vision, even if we are planning for a phakic lens?
Not quality of vision really, but because quality of vision will not depend on how epithelial maps will probably not change with ICL anyway, right?
Yes, so they won't, but once we are getting something not really like more than the usual, so like we think about planning such cases even for a laser vision correction when we do. So like if such a patient does not fit into criteria and we plan on a phakic lens for them, so does this still play a role or it does not matter?
So that will come up on eye trace. If you notice the corneal aberrations are very high, then obviously you would have to think about corneal aberrations playing a role. But if you notice here, in one of the eyes, the corneal aberrations were high, the right eye. And this is actually post-op.
Yes, sir.
Can we see
Yes.
the pre-op eye trace of the right eye? Yeah, so even if you look here, the corneal astigmatism is showing as much higher and the internal aberrations are much less. But if you look at the aberrations, they are mostly astigmatism only and nothing else, right?
Yes,
So
sir.
had it been something to do with and then the astigmatism is also showing up as a symmetric bow tie and everything is kind of fitting into place. So if you had some funny kind of irregular astigmatism with coma or something, and then the
Yes, sir.
epithelium maps were abnormal, you could have thought, and especially if the patient was not improving with correction,
Yes, sir.
then it would have been a situation. Here,
Yes,
I
sir.
don't think there would be a problem. Yeah.
And so also the reason that in this particular case we did not think about doing a phakic lens despite of like a borderline corneal thickness was because of the magnitude of the refraction that we have with the availability, or there is some other reason also for that.
What was the AC depth? I don't remember. Can we
So
check
it
the
was
AC?
it was around 3 that time.
It was
So
three
that is
plus.
why,
It's actually 3.77 and 3 point pretty good. In
yes,
fact, this
sir. So,
patient could have
and
been an
with
ICL candidate. I don't know why we didn't do it.
because
So,
the thickness is corneal thickness is borderline, and also after everything we were reaching 270, and we planned a
Absolutely.
little of the undercorrection that way. That is why.
This may have been a good candidate for an ICL. I'm wondering why we didn't do it actually. If I look at it today, I would have probably wanted to do an ICL rather than smile for this patient, especially because the Paki is borderline. We must look back and try to find out why we didn't do an ICL. Dr. Ruchika, would you remember why we didn't do an ICL for this patient?
Not really, sir. Uh, Also, I have one that slide where you showed Tulsi the planning of the smile treatment. Was
Huh.
that the planning page or is this the final treatment
This is
page?
the final treatment. Yeah. See the bottom part. The first part is top is the diagnostic data, treatment data, and then the final data. So this, and you can see on the bottom right that this is post-op.
Mm.
I mean, once the thing has completed. You know what I feel why we didn't do an ICL in this patient is because the left eye was showing. Can we go back to the refractive error for the left eye?
3 point.
Yeah, so see, it was a very small refractive error. Corneal thickness of 490 was adequate to correct this quite easily. So in the left eye, we would have thought that, ICL would be an overkill in spite of whatever. And in the right eye, we probably thought that since it's borderline and, we can get away with almost a full correction with smile, then why go to an ICL? And we never anticipated that the astigmatism will not kind of correct completely like this. So this was a surprise because we took a small risk of leaving up like a small 0.25 or a zero point 0.5 cylinder alone would probably be left behind, but it didn't happen that way, and we somehow ended up getting a full kind of a cylinder residual, which I still don't understand why it happened
Yeah,
actually.
exactly, sir. It's quite amazing that how the cylinder remains almost like what it was pre-op.
This is a real dilemma, and I would like to Dr. Tulsi can kind of get this patient's final outcomes as well. We'll present this in a good smile forum to ask why this might have happened.
shall I move on to next case, sir? Then?
Please do. Yeah.
So, our next case is a
Will
26
this
year
be the
old.
last case today?
So, if you want me to end, there are 7 cases totally.
Oh, so we'll do 4 today and then we'll do some others later. That will keep our interest alive too.
Okay. So, his refraction was minus 1.5 spherical and minus 1 cylindrical 90 and minus 1 spherical 1.5 cylindrical 80 in the left eye, improving till 6 in both eyes. And this patient had slightly steeper case and borderline packies with adequate AC depth and didn't have any signs of keratoconus. But in the 4-map refractor, but in the Bellin-Ambrosio display, there were a few elevation points which were showing up in the posterior float, and but the percentage thickness increase and corneal thickness spatial profile were falling within normal limits in both the eyes. And central epithelium map shows 54 in the right eye and 53 in the left eye. And patient didn't have much of significant higher order aberrations in both eyes. So we went ahead and did trans PRK in this patient. So except for the bad maps, everything else was within the normal limits. And sometimes the bad maps may show some abnormal points, elevated points like in this patient. And patient actually was kept on a 6 monthly follow-up, and then we went ahead and did a trans PRK in this patient, as risk of ectasia is very less. And we didn't choose for a PRK extra in this patient. And later on, when the corneal topography shows up any abnormality after surgery, then we can anyway cross-link, plan a cross-linking in this patient. So initial appearance in this patient looked like it is suspect cornea. But when we went and looked for the other maps, which were done at the same time, same day, they were not showing any abnormality in the bad maps. So this is about this case. In the next
Can
case,
we look back? Can we look back at the epithelium maps? So this looks fairly good. I mean, it's not showing any suspicious, like any suspect cornea kind of a situation.
Yeah, it is. I actually went back and checked for BFT maps also, so they were normal, all were.
Right. So how did this patient do? I mean, with surface ablation?
He did well, sir. Like he got the 6/6 partial within day 15.
Perfect. So looks good. Yeah. Oh, so this is the error, is it? I mean, just go back one slide. Yeah, this one. So we have a significant error. I mean, why is it showing so much astigmatism? Is this 15 days? So, okay, maybe we should watch it, because sometimes day 15 in surface ablations, because of the fusion line of the epithelium healing, that can show up with this kind of an astigmatism. If you look at this patient's, correction and maps post-op, do we have post-op epithelium maps for this one?
No, sir.
Okay. Later on, maybe we can see it, and then that will explain. This might just settle down, right? And as you said correctly, that risk of ectasia after PRK is usually very small. So if you have a small suspect cornea, you can still go ahead with a small PRK without doing extra procedure. But if you have a significant amount of correction and if the cornea is more than suspect, then definitely a PRK extra should be done.
So it was the last case, which was a displaced corneal
Sure.
apex syndrome. He's a 30-year-old male who had stable refraction and anterior segment, posterior segment, and all the medical history was unremarkable. And he had almost equal powers in both eyes, with -4 spherical in the right eye, -4 spherical, and -0.25 cylindrical at the 5 degrees axis in the left eye, including till 6/9. He didn't have any scissoring reflex, and there were no clinical signs of keratoconus except for one red flag here. In both the eyes, we observed that there is inferior steepening in FOMAP refractive, and but the Bellin-Ambrosio maps were all right, with CTSP and PTI falling within the range. So we thought that this could be due to a condition called as special condition called as displaced physiological displaced apex syndrome. Generally, corneas with inferior steepening on topography, they are thought to be as suspect corneas of having subclinical keratoconus. But there are some group of patients who have stable inferior steepening pattern with no other suspicious signs of keratoconus. So there is an article which was published in British Journal of Ophthalmology in 1996, where they studied such patterns of the cornea with inferior steepening, and they planned a PRK in 4 of patients who had inferior steepening, and they didn't uh, find any problem with the refractive results at 6 month follow-up after the PRK surgery. And that particular paper, they didn't do long-term follow-up, but till 6 months, the patients who had inferior steepening and got PRK done did well. So this is one classical example of having inferior steepening without any other signs of keratoconus. So our dilemma is like, should we go ahead with the refractive surgery in this patient, or should we defer it? So the epithelium.
Dr. Ruchika, what's your thought on this?
I mean, sir, these maps look very scary. Unless there has been some proven literature where like the outcomes with this have been okay. It's kind of a scary move to operate on these patients, but all the other parameters seem pretty much okay, like including the epithelial maps and everything else seems within normal limits.
Do
So
we have
possibly
a
it could
posterior
be.
elevation for this patient? Like not the
Yes, sir.
posterior, but the posterior elevation maps.
I actually took a holiday report of this. Can you see
Okay,
this?
okay, yeah, let's see that.
Tulsi?
Yes, ma'am.
Yeah. Are
In
you
fact, the steepening, inferior steepening is almost by the superior inferior asymmetry is so significant, almost 4 diopters in this patient. Like the case, like superior is like 42 or 43, and inferior is 47. It's quite scary. And I mean,
Tangential map also it's showing.
do we have the holiday report? You said you had it.
So, can you? Oh, I thought you're viewing it actually. I
No, no, we
shared
are
it.
not. Oh, we
Oh,
are
I
not.
thought. Okay,
No,
okay.
no, no. So we are viewing your PowerPoint itself right now. So maybe for that you'll have to kind of change your screen sharing and start it again.
Yes, can you see now, sir?
Yes, now we can see it. So let's see how is the back elevation. Quite amazing. Doesn't really show up anything significant. Yeah. But the anterior maps are so crazy that they are almost like 3-4 diopters of asymmetry. So what did we do with this patient finally?
We deferred refractive
we
surgery.
kept them on hold, sir. Now we've not done anything for the
Very
patient.
wise. Yeah. Also, see, the dilemma will be that suppose we had decided to proceed with this, would we have done, which procedure would we have done? A surface ablation? And if we did that, like, would we do a topo guided? Because this is going to need, the topography is quite crazy. I mean, if we just do a standard wavefront optimize, we'll probably won't get a great outcome anyway. Even if we did a PRK extra for that matter, I mean,
Right.
this would need a good topography guided treatment along with do we have the eye trace to see how much corneal aberrations are there?
Yes, sir.
So corneal aberrations are again, I mean, in spite of such a crazy map, the coma is all that shows up, and that's understandable. The astigmatism is negligible for the right eye, even though the corneal astigmatism. Okay, so what about the left eye? See, left eye shows almost 2 diopters of astigmatism, and the left eye steepening is much more than the other eye. So here, of course, it's showing almost 2 diopters of astigmatism, and the cornea is also, the aberrations are significant for the astigmatism alone, and some for the coma as well. So this is more of a coma with astigmatism in the left eye and without and the patient's acceptance in the left eye is plano. I mean, it's not plano, but purely spherical, not no cylinder, right?
No
Right type
cylinders.
purely sphericals and the left type just 0.25 cylinder minus 4
Quite
spherical.
amazing. Corneal astigmatism is almost 2 diopters. So even if we did a contura, it will be very crazy because the planning will go haywire. Anyway, I think this case needs more understanding. So while we can label it as a displaced corneal but it's highly suspect, and we should not easily be touching this cornea with a flap at least. And even if we do a surface, I would have thought of doing a PRK extra if at all. Otherwise, put on observation. Best thing is to observe for at least 6 monthly observation for a year or two, especially if the patient is understanding the why we are
And
doing that.
also, sir, this patient's refraction has been stable over many years. Like from what I remember, he's
Okay,
been a -4 for at least 3-4 years now.
right. So that's another funny thing. Ideally, we should have had a Corvus done for this patient if it was available somewhere. That might have given us some additional information. But the decision to hold on surgery is wise. And not only do we want to look at refractive stability, but even topographic stability might give us an idea. The amazing thing is that the epithelial maps are pristine.
Right,
Yes,
right.
sir.
So anyway, I think very interesting cases, Dr. Tulsi, today, and worthy of discussions. And I'm sure we can put this up on a better forum. So I think you've had a trial run today, and now what I'll do is, Dr. Ruchika, what we can do is we can put up these cases for discussion. Maybe add another 2, and put this up as one of our webinars where we can invite, like in those groups like that Deepthi Meda's group and stuff. What do you think?
Yes, sir, that will be nice.
So let's add, like what we can do is Dr. Amrita can add 2-3 of her cases as well to these. And let's have a proper good refractive surgery dilemma webinar. It'll be really nice.
Okay, sir.
Okay. So I
Okay,
think
sir.
good thought. And thank you so much for, unless any closing comments, Dr. Ruchika.
No, sir, I think this is a good discussion. I mean, it's always nice to have an opinion from a third party also, so that we have their
I was
perspective as
really
well
keen to do
first.
it today,
But
but somehow it didn't work out. Everybody's become very busy suddenly, so nobody was
Right.
able to join.
Yes,
That's
sir.
why.
Like I found out, one of my friend is working with Dr. Rishi Swaroop. So she said he's very busy with his OPD at Abbott's.
So in
So
fact, he said that he won't be able to make it because he has another engagement and he has to go out for dinner or something. And then I reached out to 2-3 other people. None of them, they said we won't be free till 9:30. So anyway, I think we had a very good discussion today. So we can just kind of gather more data post-op, like we thought of the DLI and post-op epithelium maps, and especially for that smile enhancement, if we can get post-op more data, try to do that within a week or so, and then let's present this to a larger forum and do it as a proper webinar with 3-4 panelists, right? And
Right.
okay.
I think it'll be very good. And Amrita, you can add 2-3 more cases to this.
Yes.
ठीक है ना? चलो ठीक है. Thank you so
Okay,
much.
sir. Okay,
Much,
sir.
sir. Thank you so much.
Everyone. Thank you.
Thank you, sir. Good night.
Bye. Bye.